Hi, my name is Alexis Ogdie. I'm Associate Professor of Medicine and Epidemiology at the University of Pennsylvania in Philadelphia. Today, I'm going to talk to you a little bit about one of our recent publications titled Women with Psoriatic Arthritis Experience Higher Disease Activity Than Men, Findings from a Real-World Survey in the United States and Europe. The first author is Laura Gosek, and this was recently published in the Journal of Rheumatology. So in this study, we examined patients with psoriatic arthritis in a real-world survey called the Adelphi survey. In this survey, patients and their physicians or rheumatologists complete different questionnaires, and it's cross-sectional, so just one point in time. And then we examine differences between men and women. So of the patients enrolled, patients from Europe were enrolled from France, Germany, Italy, Spain, United Kingdom, and then also we had patients from the United States. And the time range was between June and August of 2018. So among the patients enrolled, 2,270 had psoriatic arthritis, recruited by 382 rheumatologists and 190 dermatologists. Of these, about 53% were men. So mostly 50-50. Some baseline characteristics, they were your typical patients with psoriatic arthritis. The majority in this particular study were white, so 90% given the places where the patients were enrolled. The mean BMI was 26.8, and 24% of patients were obese. So when you look at the subset in the United States, that's slightly different. All right, let's start with some of the patient demographics and disease activity measures at baseline. When we compared women and men, the age among patients enrolled was very similar, it was around 48. There was a difference in the proportion of patients who were working full-time. So about 70% of men were working full-time as opposed to 50% of women. Comorbidities were slightly higher in men. The average Charlson comorbidity index was around 1.5 compared to 1.1. So very similar, but statistically different. And the Charlson comorbidity index is not a great marker of comorbidity burden, but in this particular case, it was one of the easy metrics to use. We looked at time from symptom onset or in psoriatic arthritis duration, time from onset of symptoms to diagnosis, and then total duration of PsA. The total duration of PsA was actually quite similar. And while not statistically different, there was a little bit longer time from symptoms to diagnosis in women, about 1.5 years, as opposed to 1.14 years in men. Tender and swollen joint counts, when we looked at those, they were actually statistically similar for tender joint counts, about 3 in each group. But for swollen joint counts, men had statistically significantly more, although it was not that much more. So about 4.5 swollen joints compared to women was about 4.1. Body surface area was around 5.5 for both groups, so quite similar. Enthesitis and dactylitis, there was slightly more enthesitis in men than women that was reported. And inflammatory back pain was similar, and sacral ilitis was similar in this particular study. So then when you look at swollen and tender joint counts, the proportion of patients with a lot of tender joint counts, for example, was slightly higher among men than women, and same for swollen joint counts. So then let's move on to disease impact. So when we look at the objective measures of disease activity, they were quite similar between men and women, although slightly maybe more for swollen joint count in particular in men. But then we look at disease impact, so quality of life, the psoriatic arthritis disease or impact of disease questionnaire, work productivity, and then the HAQ. All of these were a little bit different between the two groups. So women in general rated their quality of life as worse. They rated their function as worse. Their PsA scores were higher among women compared to men. And then their WPAI, or the kind of work productivity index, was also more hampered in women than in men. So the moral of the story that we kind of tell through these data is that while men and women had similar disease activity measures, women tended to report higher disease impact. So why might that be? This is kind of the critical topic of a lot of different studies right now. One thought is that there are hormonal differences in how patients may respond to therapies. Maybe there's continued inflammation that's higher in women. Maybe there's an impact of obesity that wasn't specifically examined in this study. There does tend to be more obesity among women than among men. Fibromyalgia tends to occur more commonly among women than men, so that might be impacting here, and that wasn't specifically measured here either. And then finally, there may be other genetic reasons or biologic reasons why this is different. But right now, we don't really have a good understanding for that, but it is important to recognize that there are differences. And there are probably different ways in which we might want to treat these patients then too. So for women, we might want to target more of the things that are going to help with quality of life, in addition to the biologic therapy, whereas some of the male patients may not need that as much. So while we may not take this into account specifically when giving a certain therapy, but thinking about the holistic treatment of patient may differ between men and women.